Hello, everybody. Are folks on the call able to hear me? Yes. Thanks for responding, y'all. Thank you all for joining. My name is Ishbel Correa Narvaez. I am the program coordinator for the Office of Health Equity, Diversity, and Inclusion here at Albany Med. As part of our April programming, since April is the National Minority Health Month, we partnered with the U.S. Committee for Refugees and Immigrants, Albany, to discuss more about the healthcare needs and barriers for the refugee community locally. While there are many reasons why a family may have to flee or be forced to flee from their homes and country, as healthcare providers, it's important to understand the potential barriers to healthcare. So we are not only able to provide the services that they need, but also stand in solidarity and advocate for change in the communities and policies and practices. This program is being recorded and will be made available to watch via YouTube. You could find our program's playlist on the intranet on the Workforce tab under Center Services. It is now my pleasure to introduce Emily Smith and Carlene Hawthorne, did I say it correctly? Thank you, who will be leading the presentation and discussion today. Thank you.
Okay. Thanks, Ishbel, for that introduction, and thank you all for joining us, whether you're in person or virtual. My name is Emily Smith. I'm the Health Access Program Coordinator at the U.S. Committee for Refugees and Immigrants.
And my name is Carlene Hawthorne. I am a licensed social worker with USCRI.
So we are here today to give a little introduction about our organization, different programs and services that we offer, and then speak a little bit more specifically about some healthcare disparities that we see with our clients and the population that we serve. And towards the end of the presentation, we'll have some time for discussion. Okay, so first, just to give everyone a little bit of an overview of our organization, USCRI stands for the U.S. Committee for Refugees and Immigrants. Although it is somewhat of a government-sounding name, we are a nonprofit, nonpartisan organization that advocates for refugee rights worldwide. So we have a field office here in Albany on Pine Street in downtown Albany, but we also have affiliate and other field offices throughout the country. Our mission is to protect the rights and address the needs of persons in forced or voluntary migration worldwide and support their transition to a dignified life. Okay, so first, it's very important to distinguish between a refugee and an immigrant. Both of those words are in our title. At times, refugee is used kind of as an umbrella term to distinguish individuals that are from other countries, but the different definitions have different legal implications and can determine what an individual has access to in terms of benefits. So a refugee is actually someone who is forced to leave their country of origin due to reasons of race, political opinion, social group, and that differs from an immigrant in that typically an immigrant chooses to leave their country of origin to travel to another country. Of course, that's not all-encompassing. There are different exceptions that can be made, but in general, that's the distinction. So we will talk about other individuals that we serve because we do not just serve refugees and immigrants. There are individuals of other statuses that are eligible for our programs, but we'll get to that in a little bit. Okay, so I would just like to touch on some of the programs that we offer at USCRI. Probably our biggest program and the program that most of our clients have the most interactions with is our reception and placement program. So reception and placement, or RMP, is case management for new arrivals who are resettled in the Albany area. So they receive case management and are connected with affordable housing that's accessible to bus lines and other services. They're given supplemental food or are shown how to access supplemental food until they do start receiving food stamps. We assist them in applying for DSS benefits because most individuals are eligible for these benefits. We also help them get enrolled in school for any children that are school age and are eligible, and we also help parents enroll in ESL classes. Another part of this first 90 days of the reception and placement program is community orientation. So we do offer community orientation courses. Right now they're being offered over Zoom, where we have interpretation, and it just helps our clients gain a little more context and information about Albany specifically, things like the weather, different cultural norms, and more of an opportunity to ask questions and kind of ease that transition to being resettled in Albany. So after those first 90 days, some individuals are self-sufficient and ready to get going on their own. They find employment, their DSS benefits are active, but there are definitely individuals that need a little bit more support. So we do have other programs that are able to assist clients post those first 90 days. One of those programs is our employment team. So our employment team helps clients identify jobs, apply to those jobs, practice interviewing, resume writing, things like that. We have the Health Access Program, which I am the coordinator of. This is intensive case management for individuals that have acute health needs. So I do a lot of scheduling appointments, helping clients manage their health needs, getting to the appointments, and kind of connecting them with the necessary specialty services. We also have a Making a Connection Youth program, which is for refugee youth, and they are connected with mentors in the community. We have a Services for Older Refugee program, which is, again, intensive case management, but geared towards helping older refugees gain citizenship through citizenship preparation classes. And then finally, we have a new program, which is Mental Health Services. Carlene will talk a little bit more about this in detail later, but this is a new program where we are able to offer in-house mental health counseling. Some other important programs I want to mention are our legal services. So we have a legal team at USCRI that helps individuals with adjustment of status and application for green cards. And then another event that is not specific to USCRI, but is a general community event, is the Refugee Roundtable. This happens quarterly, and it's an opportunity for community organizations who work with refugees and immigrants to come together, present about different initiatives that they're working on, and it's a really great discussion to talk about the status of kind of refugee and immigrant needs in our community.
All right. So Emily discussed the formal definition of what a refugee is. Now we want to give you a little bit of a clearer idea of what the refugee population looks like here in the Capital Region. USCRI has worked with clients, refugees from dozens of different countries, but we wanted to highlight the 5 countries where the majority of our clients have come in over the last several years. And so the first one is Afghanistan. We will be talking a lot about Afghans and Afghanistan itself since in the past year, since August of 2021, we have received over 350 Afghans. And that was a pretty historic number, since usually an average year, USCRI will serve about 400 people. So 350 just in a few short months at the end of 2021 is pretty significant. And the majority of the clients that Emily and I are working with are from Afghanistan. So we'll be talking a lot about them. But we also have received many refugees in the past several years from the Democratic Republic of Congo, from Burma, Iraq, Syria, and then Ukraine. We wanted to mention Ukraine, put a little star next to that because we imagine people are wondering if we will be receiving Ukrainians here in the Capital Region. The answer to that is yes. We've heard some have already started coming, not through USCRI, but we are anticipating more. We're just pending official guidance on how many will be coming and when they will be arriving. But we're preparing, and we know other community agencies are preparing to receive Ukrainians. And one of the reasons that we feel confident that Ukrainians will be coming here is that refugees are placed in places, in communities where they have connections. So whether that be family members, friends, or just an already present group of people from that country. And as you can imagine, that really helps with the transition to have people from their country here in the community. So that's what I'll say about Ukraine. I did want to touch on a little bit of legal status. We won't get too deep into it, but we're using the term refugee, and we will use that term throughout the presentation as refugees, but we did want to highlight that not all of the clients we work with have that official refugee status. We also work with asylees. Those are people that are already in the U.S. and seeking asylum for similar reasons to the refugees, basically fear of returning to their countries, but the main difference is a refugee status is given before arrival to the U.S., and an asylee is already in the U.S. Seeking asylum. SIVs, which are special immigrant visa holders, that is a specific status that was created for people from Afghanistan and Iraq that served and helped the U.S. military over the past 2 decades, mostly in the form of translators and interpreters. And those SIVs do have a path to a permanent status here in the U.S. And then the last one on the screen that is really important for us to mention is humanitarian parolees. And we wanted to mention that term because the majority of the Afghans that have arrived since August of last year are actually are part of this status. And when we hear parole, we think it's like you've done something wrong and you're being monitored. That's not the case. It's just the term that's been given. So they're on humanitarian parole. And the important thing to know about that is it's a temporary status for 2 years. And there is not a pathway for them to permanent residency or citizenship. And so, as you can imagine, that can cause stress since they know they're currently only protected for 2 years. Our legal department and other lawyers in the community are working with that group to find a more permanent path, and things can change with legislation, but I just wanted to highlight that. So we're talking about refugees, but in a lot of cases, they may be parolees, SIVs, and other statuses. One other thing that I do want to mention about the parolees is that they are eligible for a lot of the same benefits that refugees are eligible for, meaning they are able to get health insurance, DSS benefits, food stamps, things like that, and they are also able to work here legally in the U.S. With that status.
Okay, so we want to talk also about healthcare because we're talking to a lot of people today that are involved in the healthcare system, and we have a ton of clients that are interacting with Albany Med on a daily basis. So I just want to touch on some of the health trends that we've seen. I'm not a medical professional, so these are really just things that we've observed in a lot of our clients. And one of the most prominent things we've seen have been mental health conditions, and a lot of this is related to trauma. Carlene will talk more specifically about some of the mental health conditions that we've seen. In addition to that, pregnancy has been very prominent. In the past 3 months, we've had 21 pregnant women and counting, a lot of whom are going to Albany Med for their prenatal care. Latent TB is also very common among this population. We're working very closely with the Albany County Department of Health to make sure that the individuals who do have latent TB are following up with appointments and making sure that they're receiving the care that they need. Another common complaint that a lot of our clients have is stomach pain, in general, abdominal pain. Kidney stones have been very common, and different wounds. So any clients that have experienced these health needs, we try hard to make sure that they're connected as soon as possible with the specialized care that they need. And as you can imagine, there are a lot of challenges and barriers to care for this population. Even for someone who's grown up in this country and is very familiar with our health system, it can be really overwhelming. So for a lot of our clients, there's a huge shift from wherever they're coming from to our healthcare system, and it takes a long time to get accustomed to it. So one of the things that was definitely a challenge when we did receive this influx of clients from Afghanistan was getting caught up for their health benefits, so their insurance coverage. It did take a long time at the beginning for our clients to be covered under Medicaid, and luckily most of them are now, but that did cause a lot of confusion when clients had a very serious health need. They either went to the emergency room or a doctor's office, and then receiving a bill in the mail did cause a lot of stress because they were unsure how they were going to pay for it and whether or not they would have to pay for it. So luckily that's something that is improving, but did cause a significant amount of stress for our clients in those first few months of arrival. Interpretation is always a challenge for our clients. We are lucky enough at USCRI to have in-house interpreters that are pretty much available at all times. I do know that it can be frustrating as a healthcare provider to have a client in your office who speaks another language and maybe a phone interpreter is not available for that language. So we do know how frustrating that can be, but it's also extremely frustrating for our clients. Maybe they took the entire day to go to this health appointment, they got childcare for their kids, and they can't even be seen because there is no interpreter. So that's definitely always a challenge that we're trying to find ways to address. In addition to that, just the ability to make, manage, and get to appointments. Our clients, a lot of them can use the bus system here, but going to a place like Albany Med that is so big, maybe they need to see a specialist, just navigating that, especially with a limited knowledge of English, can be really challenging. And then in general, in some of our clients, there is a lack of health literacy and knowledge of their general health history. When clients did arrive from Afghanistan into the United States, they were sent to military bases while they processed their Social Security applications and received some necessary vaccines. So there was healthcare on those military bases, but for a lot of our clients, those are the only medical records that we have. Some clients, they don't exist, these medical records, or they were unable to bring them to the United States with them. So that's always a challenge that we're trying to face. As an organization, these are all challenges that we hope to mitigate, but of course, there are clients that want to try and do things on their own, and these are just a lot of the barriers that we've noticed.
Okay, so Emily discussed the importance of interpreters, and I want to expand a little bit on that point. And just emphasize the importance of having trained medical interpreters available for all, either refugees, immigrants, anyone whose first language is not English. And so having interpreters available reduces the risk of misdiagnosis, medical errors, and poor quality of care, in addition to repeat visits. As you all know, the capital region is quite diverse. The last number that I saw was about 17% of the capital region population speaks a language other than English as their as their native language. That number may even be higher at this point. So of course, it's best practice to have interpreters available for all patients, but it is also a matter of law. In the year 2000, then President Clinton signed an executive order that states that any organization that receives federal funding is required to have interpreter services available for patients. And then people are also protected under the Civil Rights Act. So basically that says that not having an interpreter available for someone can be considered discrimination based on someone's country of origin. So best practice and just protected under law. And I wanted to mention a few things about interpreters. Emily and I interact with interpreters almost daily. Whenever we're having a client interaction, we're using interpreters, sometimes in person, sometimes over the phone. And a few things that we are taught when we start working at USCRI. The first point is that we strongly discourage the use of family members as interpreters. And there's a few reasons for that. They're not typically trained interpreters when it's a family member, and a lot of people have their cousin or whoever has been here many years, maybe their spouse worked in Afghanistan, for example, with the U.S. military, so they speak English, or maybe it's their children. Their children have been in school here for many years, they're bilingual, they offer to step in and be an interpreter. But we strongly discourage against that, again, the formal training, but also it can kind of put that family member in an awkward situation. You can imagine if it's like a pregnant woman, it may not be comfortable for her to discuss a medical issue with her child as the interpreter. There's also things that we'll get to, like around domestic violence, suicidality. It's just best to have an outside person serving as the interpreter. And then the other point that we're taught with the use of interpreters is even like eye contact and body language. We are taught to look at the person, even if we're talking through an interpreter, we're not looking at the interpreter, we're looking at the patient, the client themselves, and we're using the words like you, what's bothering you today, how can I help you, as opposed to ask her this, can you tell her this, and then looking away, because we know a lot of communication is body language, eye contact, picking up on their facial expressions. So definitely those are some tips with the use of interpreters, and I imagine here at Albany Med you're already quite familiar with the use of using interpreters to communicate with your patients. So now I want to talk a little bit about some of the mental health issues and concerns that refugees and other immigrants experience. Emily highlighted some of the health issues. And I just want to mention, as a social worker, I am serving basically as a counselor with USCRI. This is a new position that was created thanks to a grant that the company has been wanting for several years, to have someone in-house to provide counseling to the refugees that we work with. And the reason for that is to just reduce a barrier to care. Instead of having to make an appointment with an outside provider, just having someone in-house kind of makes that process a little easier for the clients that we work with. And mental health concerns are quite high among refugees, as you can imagine. I want to share a few statistics that are from UNHCR, which is the United Nations High Commissioner for Refugees, and that agency basically oversees refugee resettlement worldwide. So they are like the top agency with information about refugees. So very reliable source for what we're looking for. And UNHCR indicates that the average refugee has survived 6 highly traumatic events in their home country or en route to another country. And trauma among refugees and all immigrants can occur before, during, and after arrival to the United States, as you can imagine. In home country, people are fleeing and being forced to leave due to war, violence, people witnessing violence against maybe even members of their own families, their neighbors. There may be natural disasters and extreme poverty that they're experiencing in their home countries. Then leaving their country, there can be further risks. There's grief and loss with being separated from their family, leaving behind their home, but there's also a lot of danger that can be encountered. We've seen on the news, of course, you've all seen like people swimming across rivers, on boats, riding on top of trains, climbing border walls, and borders themselves can be incredibly dangerous. So there's a lot of danger just getting out of someone's country. And then another area that is maybe often overlooked is trauma that can occur upon arrival to the U.S. And I'll talk about that a little bit more in the next slide, but people can face discrimination in their new neighborhoods. They may be living in unsafe neighborhoods, poverty again, and difficulty finding employment or finding safe housing. So definitely all steps of the way, there can be trauma and various things that people are experiencing. Again, the UNHCR, they report that about 50% of refugees experience pronounced symptoms of depression, 36% experience pronounced symptoms of anxiety, and close to 30% meet criteria for PTSD. So those are pretty high, significant numbers. But I also want to highlight that the refugees that we work with and that we've seen are incredibly resilient. They have a lot of hope as well. So this same study also showed that more than 50% believe that they have the capacity to deal with the obstacles they face. So I think that's an important factor to mention. And we've been talking a lot about Afghans since the majority of the clients that we're working with currently are from Afghanistan since August of last year, when we received over 350 here in the Albany area. And this study was done actually on one of the military bases before people were resettled around the U.S. And so this was done last year. A study of over 4,000 Afghans showed that 86% experienced at least one traumatic event, and close to 50% reported experiencing psychological distress. It's just something to be aware of as we're working with this population. This slide talks about some of the stressors. I mentioned a lot of the stressors that happen here in the U.S. upon arrival. This information was actually taken from a poll of our staff at USCRI. Many of the staff at USCRI are refugees themselves. They're very aware of some of the challenges that our clients are experiencing. So you can read these. I do want to highlight the family and home country because we see that a lot. People reporting a lot of worry and stress around the family that they left behind. In a lot of cases, people left not only parents, siblings, friends, but also in many cases, spouses and children. So one example I want to share is someone that I've interacted with at USCRI had to leave behind his wife and newborn baby and his elderly parents. And so now here in the U.S., he's working a minimum wage job, trying to support himself, get on his feet here in Albany, but also wanting to send money back home to his family in his home country. His parents are unable to work, his wife is unable to work, and even his siblings do not feel safe leaving the home. And so he's having that pressure to kind of support, a family of 6. So that's been a difficult adjustment. And so that pressure can also cause a major stress when people arrive here in the U.S. And then this is the last slide that I wanted to discuss before we get to some more discussion with everyone and a hypothetical case study, but I believe warranted its own slide, and that is violence against women. This is something that I encourage all providers, all people working with this population to be aware of so that we know to assess, especially among women, for suicidality, depression, and domestic violence. One study from 2019 showed that refugee women ages 15 to 49, close to 80% of them had experienced domestic violence from a partner in the past year. 73%, and this is Afghan women specifically, 73% of Afghan women in displacement contexts experienced depression. And then this study was among Syrian refugee women, but the survey showed that about half of them experienced postpartum depression. And as Emily mentioned, we do have a number of pregnant women that USCRI is working with, and so those statistics are just good to keep in mind since those numbers are pretty outstanding. And then the last one that I wanted to mention is the suicidality, specifically among Afghan women. This was in 2018, so a few years ago, but at that time, a BBC article showed that 80% of suicides in Afghanistan were among women. That's outstanding. You may or may not know that globally more men die by suicide. So that 80% stands out, and the reasons that were cited for that high rate are domestic violence, forced marriages, and then lack of resources, especially in more rural areas, not having shelters or numbers, people just not knowing who they can call for help or how to get out of some of those situations, and so many choose to attempt or die by suicide. So I encourage all providers working with this population to just be aware of those numbers and be sure that we're assessing, again, suicidality, depression, and domestic violence. And again, I think that kind of goes back to when we were talking about interpreters, being aware of who's interpreting. Is it a partner? So are we going to be able to ask questions about domestic violence with the partner? Just some things to keep in mind as we're working with this population.
Okay, so at this point, we'd like to shift a little bit more towards a discussion. We do have a hypothetical case study, so if you can kind of put yourself in this person's shoes, and we can talk a little bit about, at the end of this hypothetical situation, what might happen next. So imagine you're a 25-year-old woman. You are a mother of 6 children. Your husband is the breadwinner of the family. Your immediate family lives by, your parents, your siblings, your friends. And you are the caregiver of your children, you've never attended school, and you cannot read or write in your native language if possible. In August 2021, yeah, that's good. In August of 2021, you leave your home country with your husband and children, and you witness just devastation and violence around you. You arrive at a military base in the United States where you stay for 2 months. Eventually, you are resettled to Albany, where your husband has a distant cousin. However, you've never met this cousin. After arriving in Albany, you go to the emergency room because you're having abdominal pain. You wait alone in the ER for 8 hours because your husband is at home watching your children. You leave the hospital with a prescription. You do not know any pharmacies in the area, so don't know where to pick up this prescription. You also don't have insurance or money to pay for the prescription. So to kind of give you an idea of what one of our clients might see, perhaps you're given a picture of what the pharmacy looks like, or the hospital is able to give you a prescription for a few days, but the instructions are in English, so you're not exactly sure the instructions for taking this medicine. You're given your next appointment, but that's all written in a language you don't understand, and maybe someone gives you a map on how to get to the pharmacy, but again, a language that you cannot read. So if some people want to put in the chat some ideas of what might happen next in this situation, this is, again, a hypothetical situation, but a very common experience for a lot of our clients.
Avoid filling the script and but still be in pain, and when I go back to the visit, I could be seen as non-compliant, but to have to navigate something like this and be in pain would be very overwhelming.
Yeah, and we do see that a lot of return visits to the emergency room because clients were not able to follow the initial instructions given to them. So I think that causes a lot of frustration for everyone when that happens. Any other thoughts about potential reactions or results of a situation like this?
I feel like I would be terrified. I don't necessarily like asking for help. So being in a situation where it's either I ask for help or I'm still, where I started, that would be very, stressful situation for me.
Absolutely. That's in the chat. Do you have volunteers that can assist clients? We do, and whenever possible, we like to send either a staff member or a volunteer to an appointment or an emergency room visit with a client, but of course that's not always possible, especially in an instance where someone's going to the emergency room. It might be in the middle of the night, on a weekend, so that's not always possible, but that's definitely a good way to kind of rectify the situation, is have someone present to hear what's going on and then help the patient navigate what's next.
If I could ask a question too, it sounds as if many folks will come here as refugees, but not through your organization, right? And so while your organization has volunteers, not every organization might, and so many people in the medical center will encounter folks who don't have volunteers who can help. Is that accurate?
Yeah, that's definitely a good point. And I also think that some clients that we work with might recognize our agency as the agency that's helping them apply for benefits or enrolling in school. So they might not even think to call someone at our office for assistance. So, my program is focused on health, but so I do interact with a lot of clients, but not all clients. So that's always something that we're trying to find ways to improve so a situation like this doesn't happen. And someone else in the chat said might avoid taking care in the future. Absolutely. Just the whole process of sitting in the ER for so long is so frustrating that someone might just say, you know what, I'm not feeling better, so I don't want to go back.
And then another response. After being overwhelmed and not figuring it out, I may think I could just muster through, which will most likely cause the situation to get worse, both physical and mental health, as well as further family instability. Yes, absolutely. Yes, I'm thinking if someone is maybe experiencing like some trauma-related symptoms, some anxiety, just the step of getting on a bus where you don't know how to even pay for the bus, what stop, and no one around you is able to help you, just that anxiety would increase. So absolutely. So the next time it might be like, yeah, maybe I'm okay. Maybe it's not worth that stress, and then they're not seeking the care that they need. Absolutely.
And I think also like the role that you play within your family context, like in this case study, the person that we're talking about was a primary child caretaker. And so that stress of being like, oh my gosh, the person that shouldn't be watching the kids all day is watching the kids all day because I'm not being seen. And that's a loss of income if that is the breadwinner of the family, quote unquote. And so that just continues, right? That day of loss of work is stressful because that could have been food for the week or anything like that. Like it just causes more anxiety outside of just this one health appointment.
Absolutely.
Too, I was thinking about just all that happens before that person even walks through the door to the appointment. Could have been hours, like figuring out childcare, figuring out how to get there, getting the money for the bus, all of those things. And then maybe they walk in 20 minutes late and the provider says, well, the policy says, 15 minutes. And just like the door literally being slammed in your face with all that effort that you took to even just show up, and then to have it, be rescheduled or something for another day would just be like so deflating. And again, like the person said in the chat, you may not even bother to try again. It may just be, that's it, and then they're not seeking the care that they need. So we have some other discussion questions that we hope will kind of just generate some thoughts and some thinking about what we can all do, our agency, Albany Med, how we can work together to hopefully reduce some of these barriers for the clients that we're talking about. So we talked about a case study. Now think about your own experience with seeing a healthcare provider. From just that first step of picking up the phone and calling, finding a provider within your network, calling that provider to make an appointment, and then the whole process of getting seen and then given follow-up instructions. So hopefully you can think of the last time that you saw a medical provider. And so thinking about that, what are some barriers that a person that is new to the United States may experience?
Well, if I could just mention, having gone through an experience with a child where there are very few child-focused individuals, I think being able to navigate the piece, okay, so I need a pediatric provider versus an adult, and I have to be concerned if that person's in network versus out. I really could not even imagine what that would be like with multiple different social, political stressors going on.
And even just calling to make the appointment, the person speaks English, and maybe even asking for an interpreter can be hard. We try and walk people through that, how to request an interpreter, but that would be intimidating to even make that appointment.
I find a lot of times too that do speak English, when they're calling to make an appointment, there's all the options. Press this option to do this, press this option to do this. And sometimes even that phone call alone before you speak to someone is so overwhelming that you kind of just give up.
Yes, yep, exactly. Yeah, that phone system, and it's usually English and maybe Spanish, which helps people that speak Spanish, but all the languages that are needed are not on there.
One part that I found very shocking to me, while not necessarily healthcare focused, was being asked my race and ethnicity, like those demographic questions that are often asked. When I lived in Puerto Rico, we were all just Puerto Rican. It wasn't necessarily recorded. So moving here to the United States, that is such a racialized society, was definitely new, and finding what is my place. I distinctly remember for the standardized testing, when they asked, what's your race? I asked the teacher, my ESOL teacher, I was like, I don't understand. I don't see Puerto Rican here. He was like, well, you're light skinned, so just say white. And that's how I came to understand the concept of race at that age. So I can't imagine being older, having to kind of understand that culture shock aspect.
Also, in that same vein, just thinking about all of the paperwork that you have to fill out an appointment. I touched on not having a lot of health records, but, you know, there's words that someone who does speak English fluently might not even recognize, or the medical terminology. So that can be really overwhelming as well, not knowing what to put on the medical forms that you have to fill out. Okay, we'll move on to the next question. So now we'd like to hear if anyone has experience working with refugees and some barriers that you witnessed that would have made it more difficult for the patient, or what barriers made it difficult for you as a provider or a staff member working in an office.
The system is not designed to really take care of culturally and linguistically diverse populations. And so just when we consider the cost of translation services, we have to wonder how that also dissuades providers from using services. And so the system isn't structured in a way that ensures that the basic services can be offered in a timely fashion. Just, you know, as someone who has worked with populations such as this, so and makes it much more difficult. And as providers, we do have to have a sense of cultural humility and curiosity about people's experiences. And I think that lack of cultural humility can make it very difficult to connect with patients.
Dr. Mack, would you like to unmute yourself to speak?
Sorry, I was just going to say, working with patients who are refugees, that they often don't have an extensive, I'm not saying everyone, but they may not have an extensive social support network. So in terms of the, you know, we see it on labor and delivery sometimes in an acute setting where, you know, they don't have someone to watch other children, or the transportation system is, their transportation options are limited. And so therefore, you know, birthing people end up birthing alone because the only support network is with the other child, for example.
Absolutely. And another thing I just thought of too is the amount of patience that's required. You know, we're all working in a time where every office is extremely understaffed. So then adding that extra time to access an interpreter on the phone, doing a little more education and explaining than you might have to for your average patient requires so much patience of doctors and physicians and anyone who's interacting with clients who speak another language.
Yes, and the point the doctor made about the lack of social support, that's a major stressor that was listed, is just that isolation. And we definitely see that specifically among women. They were used to in some cases, having like siblings close by or parents, and then they come here and maybe it's the husband has a distant relative. And so that isolation, even though they're with their family, they're incredibly more isolated when they come to the U.S. Let's see.
That's a great comment in the chat, and we actually have some resources at the end of the PowerPoint, both from the CDC and UNHCR, that give very specific information for different countries, and you can kind of look up, you know, a specific country. It gives information about cultural norms, practices, and then common health trends from those areas. So we do have that information at the end of the PowerPoint.
Yes, Yes, and Nancy, I'm glad you made that point, because that's something that we're always learning, and definitely, like, I think I've gotten more familiar with just asking questions, even though it may be like an uncomfortable situation. It's like, okay, you're a man, I'm a woman, you know, what's the norm, or what will make you comfortable, and just being transparent. And then I think just being aware that we're always learning, and even if, you know, what is a norm for one family from the same country may vary. So absolutely, but yes, we'll provide some resources that we have, and then definitely we just commit ourselves to always trying to learn and acknowledging that, you know, we're definitely not experts on this, and so being comfortable with asking can help as well. Okay, great. So we'll move on to the next question, and a lot of this we are talking about, but we really wanted to discuss some of those biases that maybe are present within ourselves and the system that make it hard for refugee clients, immigrant clients, that basically cause or impact their ability to access health care.
You know, a bias may be in the example which you had talked about earlier about, you know, if there is a socioeconomic bias where people have independent transportation, then that's going to show up in the policies and practices in the clinic, where if you're 25 minutes late, then you lose your visit. And but that's rooted in this sense of, you know, independence around, you know, economics. And then that gets codified into policy. And so I think it's helpful for us all to kind of step back and see how biases around multiple things get codified into our practices and then disadvantage lots of different people.
One that I have both seen and experienced is the language biases, kind of assuming that a person doesn't understand or know English when they in fact do, or the example that y'all made earlier, speaking to the interpreter directly instead of talking to the patient. I remember after, like, I just helped my mom to a doctor's appointment because she had big surgery. And so I was just there as a support, and the doctor came in and sat in front of me and started talking to me about my mom that was in the same room. I was like, my mom knows better English than I do, y'all. You stop talking to me, speak with her.
And Michelle, thank you for your comment in the chat about needing that extra time for communicating and making sure that everything's understood.
Definitely, yeah, the time factor. Yeah, and then one thing that we were kind of discussing with some of our staff was often, like, refugees kind of then get, like, just labeled as, like, just a refugee, and, like, that becomes their whole identity, when we know that is not their whole identity. That is the status, and it speaks to the country that they're from. So I think being aware of that too, that yes, someone may be a refugee, but they have an identity outside of that, and so there can be, like, just a way that maybe people view them, or maybe just assume they came from extreme poverty and were living in a camp, and that's not always the case. I mean, we're working with professionals, professors, people that, you know, had great lives, really nice housing, you know, great lives, that they were really sad to leave and didn't choose to leave. So I think kind of keeping that awareness too. You know, we're talking about refugees, but you know, there's an identity outside of that is important to get to know, and, you know, just ask them, you know, and then again, like, a lot of the people we work with are bilingual. Their English is great because they were using it, and so just, like, not making certain assumptions is just important to keep in mind.
And even, like you mentioned, the assumption that their current work is a reflection of their education. There's been plenty of folks that I have met that were doctors in their home country that were all these different professions, yet because of the language barrier, they can't secure the same type of work in the United States. And so there's always that assumption when they're like, oh, you work as a janitor, okay, instead of recognizing that one's profession is not correlated with their intelligence.
So for our next question, we're curious. We're wondering if anyone utilizes any resources to help make healthcare more accessible to some of the communities that we're mentioning. I think just having a discussion like this is really great to kind of talk through some of the things that we've noticed and different trends. So we're really appreciative to those that are attending and just learning about our organization and a lot of our new neighbors in Albany.
Yeah, language line, definitely. Yes, language line is always amazing to me with different dialects that I've never even heard of. They can get someone in a minute, which is great. Yeah, and WIC. You're allowed to.
Yep, we have a lot of our clients help enroll clients in WIC when they arrive, so that's definitely an excellent resource. Nancy, could you elaborate on memory complaints? Are you talking neurological conditions or?
Something that I have heard that we're trying to get funding for now in regards to birthing people is the utilization of doulas to kind of give that more individualized support to patients. So I have heard from other members that their institutions had utilized, like hired doulas to kind of be there every step of the way with the patients to really take care of them and provide that personable care before the doctor gets in for, you know, the hard part, the delivery.
Yeah, definitely, and that's something I've found working with so many pregnant women, and Albany Med has actually been flexible in making sure that clients are able to see female providers. And Ishbel, like you mentioned, incorporating doulas into that process, especially female providers, would be really helpful.
Oh, yeah.
Thank you for clarifying, Nancy. Any opportunity to translate appointment reminders or brochures, medical information into someone's native language is always very helpful and best practice.
Yes, I see the question about if the refugees and clients we work with have a preference for in-person interpreters or over the phone. Yes, and that's something, that's a great question, and I don't know if there's 100% an exact answer, but that's something I'm always trying to figure out, especially with like talking about mental health concerns. We've definitely found that a lot of the people here, a lot of our refugee clients, they know all the interpreters because they're in the same community, they may be neighbors. And so in a lot of cases, having someone that they don't know at all can really help to kind of give them a little more comfort with talking about sensitive issues. And then in person or over the phone, I think that also depends. I think in some cases in person makes it a little easier because, you know, you don't have like the phone connection issues. But with that, it's also like now you have a third person in the room, so it's like a three-person conversation. And so I think it depends. I also think gender can be a factor. with that. Like, I know I'm still, you know, new to the agency, but like when I have a female client but a male interpreter, I prefer to have that male interpreter over the phone because I think it's then just a voice as opposed to having a man in the room, just with some of the cultural preferences. So not a super clear answer other than it depends, and it's something that I'm always thinking about, talking about with supervisors, asking the clients themselves. I don't know if you have any thoughts on that.
Same sentiment. And Julia, thank you so much for that comment. I think that's a really wonderful idea and would make things more inclusive.
Yeah, it's a great idea. So fast. We so appreciate the discussion. One thing I do want to mention, we have resources here. I saw there were a few social workers in the chat, so I encourage you, and you can also email me, but to just Google, if you haven't already heard of it, the RHS-15. It is a mental health screener created specifically for refugees. It's been translated into at least a dozen different languages, and it's been translated by refugees themselves. So like the cultural wording matches. It's not a long screen. It's 15 questions, and it can give you an idea on depression, anxiety, and trauma-related symptoms that someone's experiencing. It's not a diagnostic tool, but it's a great, just like, again, screener to kind of check in with someone, see what their pressing issues are. And then if there's guidance on it, if like the score is above a certain number, that it's recommended to refer them to counseling. So RHS-15, you can Google it or you can email me. We'll provide our emails, and I can send you copies of it in the various languages that we have.
And then these last two links are the website, the CDC and the UNHCR, which gives country-specific information for both health conditions and cultural practices.
Please feel free to take down our email addresses and email us directly. And at the bottom, we have our office phone number and general inbox that is checked daily, and staff check it and make sure the messages get to the right people. Yes. And our director in the chat, Jill, provided some information about how to get involved. So please review that chat and take down that information.
Thank you, everybody, for joining the program once again, both in person and virtually. We're really grateful to have you all here to engage in this discussion. Please, again, reach out to either Carlene or Emily if you have any more questions or you want to engage further with their organization. We again, appreciate you all. As a reminder, our next program will be tomorrow, our monthly series of Code Switch, Microaggressions, and More Less Discussed. The topic will be on the minority tax. So feel free to join us virtually or in the Hayek Auditorium from 12 to 1. Thank y'all.